Hello everyone, I'm Dr. Rob Dickson, Medical Director for the Montgomery County Hospital District EMS in Southeast Texas. Thanks for joining us for this informational presentation and Q&A about the exciting new developments in the vaccines for COVID-19. So today on our panel we have myself, Dr. Casey Patrick, who's our Associate Medical Director.
James Campbell, Chief of EMS.
And Sean Simmons, our Safety Coordinator for the district.
Yes, sir.
So let's get started. Let's talk about initially the Pfizer vaccine. This is a 2-dose regimen, 3 weeks apart. It's a messenger RNA vaccine. What does that mean? Messenger RNA is really a blueprint for the SARS-CoV-2 spike protein. And this spike protein is a protein that's expressed on all the viral particles that allows it entry into our cells. Remember, a virus cannot exist on its own for long. It has to have a living cell to infect. So this messenger RNA is simply a genetic recipe code. It's wrapped very cleverly in a lipid membrane to allow entry into our cells. So you get the vaccine, it enters into our cells, and this messenger RNA gets translated to the spike protein, which is expressed on our cells. Our bodies see that as a foreign invader when in fact it's not. It's not live virus, it doesn't infect the cells. It's just fooling our cells into thinking that there's an infection. It fools our body to thinking there's an infection. That way, when our body sees the real spike protein from the virus, it can react and kill the virus. So remember that the messenger RNA acts like a temporary recipe for the cell to make the spike protein. The Moderna vaccine is a very similar messenger RNA vaccine. It's just spaced a little bit differently. It's a 2-dose regimen that's spaced 4 weeks apart. Here's a nice illustration of how these messenger RNA vaccines work. So you have this genetic code, which is non-infective. It won't do you any harm. It's wrapped in this lipid membrane, and that allows it entry into the cell. Once inside the cell, it can be translated by our normal cellular process to make these proteins, which are then expressed on our normal healthy cells. These don't hurt our cells, but what they do is they stimulate our immune response to recognize these spike proteins as foreign invaders. So henceforth, we have the vaccine. Once we see the real virus with all these viral particles expressing the spike protein, our body will recognize that and be able to fight against it. So spike proteins are seen kind of all over these viral cells. Remember that mRNA that's in the vaccine does not alter your cell's DNA. It's not permanent. It will cause your cells no harm. And there's no live virus produced by these vaccines. They will not cause you illness. There's no risk of getting the virus from this vaccine. So one of the common questions we get here, and I'll pivot to Dr. Patrick to explain this or give an explanation of it, is this a new technology? I'm worried because it's mRNA technology I've never heard of before.
And it's an excellent question. And as far as going all the way to the finish line, producing an mRNA vaccine, these are the first. To answer that question, yes. Now, how long has this technology been in development? The answer to that question is decades plus. One of the more amazing parts of this entire pandemic was how quickly the viral genome was sequenced. And that genomic sequencing, which happened very early on in the pandemic, allowed us to identify the spike protein, right? So now we know the genetic code for just the spike protein. We can take that messenger RNA or DNA particle, wrap it in that lipid, and use that as the vaccine source, right? Because in the end, the goal of any vaccine is just to prep the immune system to recognize the virus when the patient comes into contact with that virus in the future. And again, that's the whole basis why there's no live vaccine present. There's no live vaccine genetic code present. It's just the genetic code for that spike protein, and then that's the protein that allows it to enter the cell. So that's how we can target one specific sequence.
So let's get into a little bit of the nitty-gritty of the individual studies. So the Pfizer trials, about 40,000 people, and at least half of them, about half, 19,000 of them were followed for at least a 2-month period after the second dose. So really, really good follow-up. All these patients, very few of them were lost to follow-up, so they kept very close track on all these patients that were involved in the trial. This is a randomized, double-blind, placebo trial. What that means, it's really the gold standard in medicine. That means that in the groups, they're recruited, all the patients are recruited, and they recruited across many ages and genders as possible. And once you were in the study, you were randomized to either the vaccine group or the placebo group. And in the vaccine, all these, which group you were assigned to is unknown to the researchers. And so you're followed throughout the trial with none of the trial researchers knowing which arm you're in until the study is unblinded. So all the outcomes, so it's really the most unbiased type of research you can do. This is a very well-balanced study. About half the people were over 55, and many of them had chronic illnesses, which is important, right? We know that the SARS-CoV-2 virus adversely affects our elderly patients, our patients with more comorbidities. Children in the initial Pfizer run-up were excluded. Now they are bringing in some older children, 12 to 16, I believe, and pregnant patients were excluded from this Pfizer trial. In the Moderna vaccine, very similar study design, randomized, controlled, double-blinded, so the patients and the practitioners were blinded to who got the vaccine and who got the placebo. About 30,000 patients randomized 1-to-1 to get the vaccine or the placebo, and very similar demographics. About half of these patients were Caucasian, about 25% were over the age of 25. This trial as well excluded pregnant patients. In the Moderna trial, about a quarter of them had one or more comorbid risk factors. So things that we know increase your risk for severe illness with COVID disease. So chronic lung disease, significant cardiac disease, severe obesity, diabetes, liver disease, or HIV. And overall, was it effective? Let's start with the Pfizer. These are you could really just change a couple, less than a percentage point, and say they're both 95% effective, essentially. 2 weeks after the second shot of this vaccine, it was 95% effective. And what does that mean? These patients are very closely followed for clinical illness. What does that mean? It means that you had a clinical symptom and you had a positive COVID test at that time, and you were declared a positive COVID. So 95% of that population was protected after the second shot, which is extraordinarily efficacious as compared with some of the influenza vaccines, which are 60-70% effective. So very, very effective. And what's more promising is that about 80% of the patients had some protection, some level of protection, even after one injection. A certain number of people are going to miss the booster or the second shot, but there is some protection even after the first shot.
And by no means are we saying that in either of these vaccines that one dose is sufficient. It's just encouraging to know that if you had the choice between one and no dose, I'd take one.
One.
I strongly advise the second to get up into that 95% range. And some of the other details, the Moderna vaccination trial was slightly more ethnically diverse. That's one small difference. The storage requirements for the Moderna vaccine are a little less stringent than the Pfizer, and that all has to do with the lipid membrane. The lipid membrane in the Moderna vaccine is a little more stable than Pfizer's. So there are some slight differences, but all in all, these studies, or at least the Pfizer that's been fully released in the New England Journal for peer review, very, very encouraging, well done, low rates of significant side effects. Now, when we talk about it being safe, there are still going to be side effects that folks have, and these are going to include the normal side effects that we see with the tetanus shot, with the yearly flu shot, with the shingles vaccine, and that's going to be arm site pain, body aches, on the extreme side, sometimes fever and chills. And then like any other drug that you take, whether it's Motrin or penicillin, there's always the risk for allergic reaction and anaphylaxis. And that is going to be higher in folks who are hyperallergenic. That's folks that have had allergic reactions in the past.
Yeah, it usually had severe allergic reactions, and the rate of those in these studies, we'll get to that data, is very, very small. So let's get, as Dr. Patrick said, adverse reaction. This is the Pfizer, but the data is essentially the same for both. It's not much different. So pain and redness at the injection site, fatigue, headache, flu-like symptoms, chills, joint pain, so very, very common side effects. They essentially mimic the side effects of the Moderna vaccine, with both of them, the number one being pain at the injection site. But let's talk about serious side effects. Let's talk about, Dr. Patrick alluded to anaphylaxis or severe allergic reaction. How common was that found in these studies?
Less than 1%. So very uncommon. And realistically, why do we have these minor side effects? It's an immune system response, right? Anytime that you activate your immune system, it's just like when you're getting any viral infection, right? You're going to have some of those body aches and pains, and you're going to have some inflammation at the site, because that's where your T cells and antibody response is most active. So
it tells you it's working.
Tells you it's working, right? Yep.
So another one of the things I think that how closely they follow these patients is, they followed them very, very closely, and they reviewed every death that happened. If you can think of a study of 40,000 people across the age spectrum, you're going to have some deaths in there, and every one of them was reviewed. And essentially, the deaths were rare and unrelated. 2 in the vaccine group, this is for the Pfizer study, and 4 in the placebo group. So actually more people died in the placebo group than in the vaccine group. And in the Moderna vaccine, there were 0 deaths in the vaccine group and 1 in the placebo, which I think these would be not statistically different. So essentially, there is no, in these sets of patients, which are huge, huge studies, 40,000 and 30,000 patients, really no deaths or serious adverse events leading to death that happened from the vaccine, which is amazing safety record.
I believe one of the deaths was a lightning strike, for example, right? Lightning strike is not related to either the Pfizer or the Moderna vaccine, right? That's just, if you take 40,000 people from the NFL football stadium on a Sunday and you decide to follow them for 6 months, you're going to have some deaths that occur by chance, right?
Let's get into a little bit some of the questions we've gotten, and we'll bring Chief Campbell and Sean back to when we get into kind of the most common Q&A from our crews. But we get a lot of people talking about concerns about pregnancy and breastfeeding. Can you talk a little bit? There was very little data. I think 12 patients, 12 pregnant patients received the vaccine. So there's just not much data on pregnant patients. But what do we know about these vaccines in pregnancy and in breastfeeding?
So you may ask yourself, so I thought you said pregnant patients were excluded, and they were excluded at the start of the study. But what happens if you take 40,000 patients and you put them in a study? Well,
some of them get pregnant.
Some of them are female, and then some of those are of childbearing age, and some of those are going to get pregnant. And the ones that did, there were miscarriages in the placebo group, right? So some pregnant patients, percentage of them miscarry normally, right? And so that's not unexpected. The problem with any research trial and getting a trial past institutional review board, the folks that say, is this trial ethical or not, including pregnant patients, is just it's a more dicey scenario. So most researchers, most trials, if you look at any of the big trials, whether it's any drug treatment trial or any procedure or surgery, pregnant patients are inevitably excluded. And that is really just to decrease liability and to increase the likelihood that the study will get funded and actually happen. Now, what do the experts say? The high-risk maternal fetal medicine group of OBGYN doctors, those are the OBGYNs that specialize in taking care of the sickest pregnant patients. They say that the vaccine is, for the most part, from everything they can tell, safe for pregnant patients. That said, there's little data to support that. But what you have to do, and this is probably for me the most common question that I've gotten from our medics, and probably one of the more difficult ones to answer is, hey doc, I'm 32 weeks pregnant. I want to work through my pregnancy. Should I get vaccinated or not? And my answer, and I've answered this exact question to several medics, is at this point you have a known risk and an unknown risk, right? What's the unknown risk? The unknown risk is the vaccine, right? And from everything we can tell and everything we talked about, the vaccines seem exceedingly safe as compared to the flu vaccine, probably safer, right? When you look at side effects and minor and extreme outcomes. What's the known risk? Well, if you're going to work from 32 to 40 weeks on the truck, then you're inevitably over the next 8 weeks going to be in the back of the truck with a respiratory patient, coughing, hacking, fighting the vent, fighting the BiPAP mask with COVID. It's just endemic in our community here in Montgomery County now. So that is a known risk you would be accepting if you deferred the vaccine.
And we know
increased risk of COVID.
Increased risk of COVID, but also increased severity of illness. We see more increased severity, so worse outcomes in our pregnant patients with severe COVID
And
disease.
more and more data is coming forward on the high risk nature of COVID and pregnancy when it comes to respiratory compromise, premature delivery, fetal demise. All these things seem to be increased with COVID-19 infection. So my answer to our pregnant medics who wish to continue to work is that your risk of COVID and complications is higher than your risk of vaccination and complications. I don't think anyone can quantify that number and put that on a scale, but that seems to be where the OBGYN experts are falling in. I think that's where we fall in as a service.
Agreed. And since we're on the topic of unanswerable questions, we'll get to how long am I protected? And the bottom line is no one really knows for sure. There has been some data on mRNA vaccines that say they do see a good antibody response through 90 days. But remember, these trials are, they're just maturing. They're still adding patients to these trials and following the patients out. And they are following their antibody titers as a surrogate marker for protection. Remember, when our body sees an invader, it creates an antibody to that. And that antibody circulates in our blood to attack any virus that we may come across. So the antibody titers tend to peak shortly after the second dose, and they decline over time. We know that people who have a less of an immune response, so people over the age of 55, had a little bit less of this response. So we don't know about the exact duration of your immunity, but my suspect is it's going to be around where the flu vaccine is. This may be a vaccine or at least a booster that we take every flu season, just like our flu shot.
And this varies depending on the infectious disease, right? Think about tetanus shot, for example. We're immunized for tetanus and we take a booster every 5 to 10 years versus influenza. We take the influenza vaccine every year. So some of this is going to be lessons learned over time. I'm personally in the AstraZeneca trial, which is one of the non-EUA approved vaccines, hopefully coming at some point. We need all the arrows in our quiver that we can get. But it's a 2-year study. So I'm going to go every set time period and have blood drawn. They're going to look at my antibody titers over time. There's 40,000 other folks doing the same thing. And so as these studies progress and as the data matures, there'll be more research papers that come out, more information that comes out that'll tell us, did people start getting sick at a year, 14 months, 18 months? And then that will guide the researchers, guide the scientific community on the recommendations for, do we need this yearly? Do we need a single booster at 1 year? Do we need to go through the 2-shot regimen every year? And some of it also is going to depend on how the pandemic progresses, right? If we can drive the virus down to the point to where it's, like SARS-CoV-1 and gone, then there may be no need for any vaccine.
Remember, it can't live outside a living host. So as Dr. Patrick said, we immunize enough. And what is this number of herd immunity? It's a fairly large number. So it's thought to be like 2/3 of the U.S. population needs to be vaccinated. So a fair amount of people need to be vaccinated or have seen this virus before we start getting that herd immunity.
In reality, I say we should take the wonderful vaccine news that we have now, encourage use, and deal with a year from now, right? And try to drive the transmission rate down and, improve our outcomes, clear out our ICUs and our hospitals, and then let the future kind of come what may.
Agreed. What about in kids? I know that we've gone back and forth Is this safe in children? The bottom line is there's really not data to support that for either vaccine because it simply wasn't studied in kids under 16 years old. Now, the Pfizer arm has enrolled kids 12 to 15 in the trial, but there's simply not enough data to comment on kids.
Realistically, though, from a high risk group standpoint, you look at some of the groups that are propagating transmission. It does go down to 16. So high school age kids going to college, things like that. As we ramp up production, these are going to be groups that will need to be targeted and can safely be targeted, because while we can't really give it to elementary school kids, even if we can start with high school and college age kids, that may be a real win for decreasing transmission.
Couldn't agree more.
So that brings us up to time to take some service-wide questions that we've had beyond just pregnancy and pediatrics. We've had several town halls with both our medics and our first responders, and we've gotten some repeat questions, so we wanted to bring those for everybody, sort of memorialized, so everybody can take a listen, and we've kind of created these answers based on evidence, and hopefully these will help you all feel more at ease when making the choice to take the vaccine. Again, you're going to be vaccinated. I've been vaccinated. I think we would encourage all the listeners out there to move forward with this. But again, it's our job to provide you with information. We didn't make this decision lightly. I wanted to see the information before I move forward, as did you. It's entirely reasonable. So we'll bring Sean and Chief Campbell back and go through a little Q&A.
So Chief Campbell, we've heard the presentation from the doctors. Is this going to be mandatory for all employees?
The COVID-19 vaccine is not going to be mandatory for our employees. This is something that we've gotten several legal opinions on. And in the state of Texas, you can make the vaccine mandatory. We're an at-will state. You can make it a condition of employment, but that's not a route that we wanted to go with this vaccine. We just wanted to provide the information and tools for our organization so that each individual can make the most informed decision for themselves and their family.
Dr. Dickson, Dr. Patrick, can you explain the short timeline for developing these vaccines?
Yeah, we hear that question quite a bit. And are we rushing this out there? And my stock answer to that is that the process is exactly the same for the phase 1, 2, and 3 of the trial. So how we approve any vaccine or medication in this country. What's different about the SARS-CoV-2 vaccine is that now we're in a worldwide pandemic with thousands of people dying in this country every day. The world as a whole has thrown an enormous amount of resources into developing these 4 different, actually more than 10 vaccines, but 4 in this country, 2 that have emergency use authorization that we talked about today, the Pfizer and the Moderna products. But I think it's not that yes, it is shortened simply because of the resources that have been put into it, and the fact that a linear process has really turned into a parallel, i.e. before, when you had phase 1, 2, and 3, you would do phase 1, and then as scientists, we would talk about it for a few years, and then we would do phase 2, and we'd think about it and go back and talk about it for another 3 or 4 years, and then we get on to phase 3. Because of the deadly pandemic that's upon us and all the resources and the time-sensitive nature of this, those are kind of overlapped, where we did safety trials and then we immediately started enrolling people into the clinical trials here once we determined that what the dose was and it was going to be safe.
Yeah, I think some examples to think about recent vaccines that were developed and released. Take shingles, for example. There are multiple shingles vaccines. Shingles is a debilitating, uncomfortable illness that no one wants. Super painful. And if you look at the timeline, though, for shingles vaccine development, it was much longer than SARS-CoV-2. What's the big difference? Well, there are 2 differences. Number one, SARS-CoV-2 is a pandemic killing thousands of people a day, right? So there was much more of a rush on to knock this thing out as opposed to shingles. No knock on shingles, but just not the same level of urgency. And then secondly, just the amount of money that has been spent. And the amount of money is astronomical in comparison to any other vaccine development really in the history of humankind. And how does that money translate into speed? It translates into speed because it costs money to get study participants, right? To have tracking capabilities, to have space to do the study, to have staff in those spaces to undertake the study. So all of that money allows you to get those thousands and thousands, 40,000, 30,000, 35,000 participants in these studies respectively. How do you get them in? How do you advertise? How do you make phone calls? How do you send out flyers and informational devices? That's by spending money. So it's money working in parallel instead of linear, and then just the urgency.
Yeah, and the way that I want to reiterate, the numbers of patients involved in this trial are similar to other vaccines, and they're the same design of trial. They're randomized, controlled, double-blinded. So you get a placebo or you get the vaccine, you're followed for a period of time. In these studies, the median was between 2 and 3 months to look for side effects, to look for other efficacy, or to measure efficacy of the vaccine. And then they simply look and say who got symptomatic COVID disease and who didn't. So I think they were both well done, and they're both very similar to the numbers, I think very appropriate numbers of patients in both trials.
I think from a resource management standpoint, you said it best, there's all these resources to help develop the vaccine. But if you look at individual organizations, even ours, it would take us 6 months to develop a clinical guideline. We had everybody in the table, at the same table, weeks, and we did a clinical guideline overnight, just because all the resources are focused on it. So you could draw that parallel to your own organization, just with
Yeah, I think that's a great parallel too.
Is the mRNA, is that new technology, new vaccine technology?
Yeah, Dr. Patrick talked about this a little bit earlier, so I won't belabor the point, but it's just really is kind of as old as time. When you think about mRNA technology, and remember to kind of refresh, mRNA is a recipe code. It's a genetic code, and it's wrapped in a lipid membrane in these vaccine to allow it to enter the cells, and then it uses alive cells, inner organelles to produce the spike protein, which fools the immune system to thinking it's infected when in fact it's not. But if you think back to any virus, acts the exact same way. It's just simply, it can't live alone. It's just some genetic code that's wrapped in something to get it into the cells, into your healthy cells. But instead of it helping your immune system to recognize it like a virus when in fact it's not, the real virus uses the same technique, except for it actually is infectious, can infect other cells.
And realistically, since the dawn of DNA sequencing, scientists have felt like this is the key to vaccine production, really for probably 2 decades plus. This has been trialed with, Ebola being a big example, but the idea that we can sequence the DNA of these viral pathogens almost immediately and then target, cellular access points, for example, being a key, that technology is not new. A lot of similar technology now is being used in cancer treatments, right? To try to target access points for malignant cells, to try to use our body's own immune system as cancer therapeutic agents, right? So this is not new technology in the sense that we didn't just come up with this in the last 9 months. Is this the first mRNA vaccine? Yes, it is. That's been released to the public, but this technology is decades old.
Yeah, it's really gotten this quick because we're so much better with gene sequencing than we were. They had this virus sequenced very, very rapidly.
So you guys are talking about gene sequencing and DNA. I have a pretty heavy social media presence, and I've seen some concerning things. Will the mRNA vaccine change my body's DNA?
No, the answer to that is no, it won't.
Okay.
Remember, this is a temporary recipe, so it's a genetic code, and it's wrapped up. It gets into the cell. It uses some of the cell machinery to create these spike proteins, which the body recognizes as a foreign invader when in fact it's not, and allows us to mount an immune response. And furthermore, it allows our body to be primed. It primes our immune response to where if we see that infection at a later time, 60 days from now, 90 days from now, our body's going to be ready to respond to it.
Another common vaccine question with any vaccine is, will it cause the autism spectrum disorder?
So that is one that if you, speaking of social media, if you scan for the slightest time period, you're going to see this brought up. And again, at risk of, I don't want to be argumentative or confrontational with anyone out there, but there is plenty of well-vetted data, retractions. This was brought on by a British scientist, Dr. Wakefield, who's been since discredited. His research has been, again, retracted. There is no link to any vaccine and autism or autism spectrum disorders. So the answer to that question is no.
No. And I put the link up there. For people that are interested, you can go to that link. It's a CDC link that details all the science that looks at this. It really debunks this myth. I think that this doctor did a real disservice to folks by publishing some of that and putting some of that out there, which has really hung on for a long time, despite lots of evidence to say it's really not the fact at all.
And to go back to just the general nature of these studies, right? And a lot of this comes from MMR vaccine, for example, that you get in your childhood, and you get that during childhood at ages around, let's take 2 years, for example. Well, if you take 40,000 children and you give them a vaccine at 2 years, well, when is autism spectrum disorder diagnosed? Oftentimes, in that transition from toddler to childhood, right? When communication becomes more developed, right? So if you take 40,000 kids and you watch them, some are going to end up having autism spectrum disorders diagnosed, right? Is that because of the vaccine? And again, the data tells us no. It would be like saying that the MMR vaccine causes both bone forearm fractures. Well, no, it doesn't. Kids that are 2.5, 3 years old fall on the monkey bars and on the slide and break their arms. So again, correlation and causation can be confused very easily. And in this situation, we've had multiple, well thought out, responses from folks a lot smarter than myself. Data dredges and data looks that say that this just is not the case. So we'll leave it at that.
So if I've already tested positive, I should have natural immunity, right? Do I still have to get the vaccine if I've already tested positive for COVID-19?
That's a great question, Sean, and my answer is yes. You want all the protection you can possibly get. We had a question actually came up this morning. If I recover from COVID illness, when am I safe to get the vaccine? My stock answer is when you are completely recovered and asymptomatic of your disease, i.e. you're not having shortness of breath, you're not having fevers, you have no sequela from the initial infection, you are safe to get the vaccine. There's no evidence that the vaccine, if you've had previous illness, is going to be deleterious to you or cause you problems. It's going to cause you the same side effects that we went over in our talk.
And Dr. Dickson and I will link this one up too, recently did some research and wrote a small piece about reinfection and COVID-19. And there are now documented cases of SARS-CoV-2 reinfection. And some of those occurred as close as 45 days to initial infection. So, that short time period between infection 1, resolution, infection 2, my wife had COVID in late September and just got vaccinated, and we had the discussion, should she wait, should she not wait? And based on that, 45-day period in some of these reinfection cases, she was well out from that. So she got vaccinated despite being COVID positive just this fall. So,
and I don't know if we quite have characterized it or understand it, and this is not a big series of patients, but in the patient series that Dr. Patrick's talking about, 50% of them actually had more severe disease on their second go-around. So just like anything COVID, right, all the people that have sat in this room, we've changed very rapidly at a very fast pace over the last year that we've been really actively in this. And you're going to see more and more and more things come out. These vaccines were just EUA approved the first one on December 10th, and now here we are taping this on December 21st. So this moves very, very rapidly. There's always more to come.
Another population that it's worrisome, maybe difficult to do research on is pregnancy, childbirth, breastfeeding. what's the best guidance for the vaccine in that population?
And again, we hit on this in the earlier segment, but just to, I guess, summarize briefly, we know that pregnant patients are at increased risk when they contract COVID-19. We know that they have increased respiratory compromise, increased risk of fetal demise, miscarriage, preterm delivery, all things that no pregnant mother wants. And based on everything that we can see from the small numbers of patients that were in the studies that became pregnant, the vaccine appeared to be safe in those patients. So the OBGYN groups who make these recommendations, maternal fetal medicine, high-risk pregnancies, the recommendation is that the vaccine appears safe and that patients should assess their baseline risk of contracting COVID-19 and make the decision that best fits their life and their work environment. When I've got this question from our medics, realistically, if a medic wanted to, quarantine, come off the truck, not work, and not get vaccinated, probably not unreasonable. For the medics that I've talked to that want to continue working, continue taking care of COVID-19 patients, in that patient population, I am 100% recommending vaccination. Would you agree?
I would agree. I would agree.
So if I get the vaccine, will that make me test positive for COVID-19?
No, it will not. No, that won't give you a positive COVID-19 test. Remember, you're going to get side effects from the vaccine, but you're not going to test positive for it, and it's not going to give you the virus. The vaccine will not give you the virus. There's no live virus involved in this vaccine.
So we worked to develop all these guidelines to keep everybody safe, masks, gowns, things like that. Well, now once we get the vaccine, does that mean I'm good? I won't get COVID?
Very common hope. I think everybody hopes to get back to normal. And me included, I found out that I actually got vaccine this morning. Very happy that I got vaccine in my trial and not placebo. So it's been percolating now in my system for a month. That said, masks, gloves, N95s, and aerosol generating situations are still going to be 100% required. And that's because the vaccine is just one piece of the puzzle, right? While these things are effective, even at 95% effective, 5% of us are going to get the vaccine and not be, immunized. And that said, that 95% effectiveness is over, at this point in these studies, a relatively brief time period, right? We don't know when that's going to go away. Is it 4 months? Is it 6 months? Right? So just to say, okay, I got vaccinated, we still don't know the final answer of when do these things wear off and when do we need to be redosed. So what we want to do, the whole goal is to drive transmission and infection rate down. And the best way to do that is to take all necessary precautions. It's kind of like, well, I'm buckling my seatbelt, can I turn my airbag off? And the answer is no, right? Because both of those mechanisms decrease our risk, right? I buckle my seatbelt. Can I be drunk and drive now? No. Can I go 120? No, right? We abide by the speed limit. We don't take intoxicants. We use our airbags side and front. We don't turn off our crumple zones when we turn on our airbag, right? We're going to use all the protective mechanisms that we have.
Yeah, I think the proof's in the pudding, I think we would not be addressing this right if we didn't kick it back to Sean to one more time say that we put these measures in very early on here in our agencies and many of our colleagues, and we have not seen employee infections come from patients. Are we going to see employee infections? Yes, from home, from folks around you that are carrying the virus, from not social distancing, from not mask wearing. So it's not something that I want. I'm deep down a hugger, and so this is very difficult for lots of us. I think people are social and we want to get back out there and socialize. We want to do it without masks, but it's simply not safe to do so right now. If we want to get the economy back on, if we want to get things back open up, if we want to get back to the lives that we had prior to this pandemic, we need to drive, as Dr. Patrick said, the levels of this virus down to almost undetectable. And that's not going to happen overnight. I foresee in our service wearing masks really forever in every respiratory case, because there's another SARS-CoV-2 out there. It just hasn't unearthed itself yet.
So you're saying we still have to take all these measures to protect ourselves, does that mean that if I get the vaccine and I get infected, can I still spread the virus?
Great question. Another one. Well, that's kind of in the middle,
Yeah.
right? It's one of those gray area questions that no one really knows. As Dr. Patrick said, once you get the virus, we do know that there's documented reinfection. So at the time that after you get it, you're clearly not 100% protected, and some of those were in as little as 45 days. So we don't know the specific characteristics of this vaccine. How long is it going to be effective? Does it protect you not only from just disease, so from clinical disease, but also from a carrier state where I could give it to Sean or I could give it to Dr. Patrick? So great question. I don't think anyone really knows the exact answer. The other one we get is, well, I've had the vaccine, I've had a high risk exposure. Why do I have to stay off work for 10 days?
And realistically, these are questions that I've listened posed to people smarter than me. And that's the biggest question is, if I get vaccinated, does my risk of transmitting to others go down? And that's the one that takes, even at 40,000 patients, we're not going to know the answer to that. We have to assume, and again, this is an assumption, this is not a given, that if you get the vaccine and your rate of infection goes down, then the rate of transmission should therefore go down.
Right.
Now, can we prove that with the studies that we've got? We can, to answer that question honestly. That's why we have to continue masking, glove, eye protection, gown, be mindful of aerosol generating situations, and continue to use viral filters. And knowing that these are two-part vaccines at this point, right? We have two steps in both of these vaccines that are available. And your immune system's not going to be primed until after the second dose sometime. So there's going to be a 6-week time period in there after vaccination where you absolutely can get infected. Right? You could be in the 5% that gets infected even with, the full 2 doses. So the goal is to get to some point where we can go back to, I'm a live music fan, right? Like, there's no concerts in COVID-19. This is miserable for me. I would love to get back to a concert of anyone, but we've got to do PPE, social distancing, vaccination, and then see downward trend in infection, downward trend in that R0 transmissive number, whatever, however you want to think about it. So less transmission, less cases. And then when we can drive that down enough, just like we're not worried about COVID-1 anymore, we're not worried about the swine flu anymore. Nobody's heard Zika on the news lately, right? These viral infections that flare up can diminish to the point where we don't have to worry about them. But that's what we've got to get to before we can start peeling back some of these restrictions. And that is to get to, keep the economy in order, get back to some of the social things we like to do, take some of the pain out of these calls. We get it, wearing all this PPE, especially in Texas heat in the summertime, is miserable. Dealing with every single patient like they're, an infectious transmission risk is miserable in our day-to-day job. Can't imagine how it is out on the truck. I mean, I know that it's awful. And we want to peel those back, but we got to do it safely.
Yeah, and I think that's the question that we don't have the answer to. Is you get the vaccine, do you still go out if you have a high risk exposure? We don't know yet. And I think if you have an exposure, that's a problem for 2 weeks or 10 days with an employee out. It's better to err on the side of caution and not risk losing an entire workforce. I would rather err on the side of caution
I
to
think
keep us and our patients.
Yeah, and this is not had this discussion yet because we've not vaccinated yet. But my answer is, after the first dose, you're not, you're in the 80%, 70% range. So for sure, within that first month period, if you have a high risk exposure, I think we're still going to be putting people off. Probably after the second dose, to be honest, because it's not 100%, right? And I go back to another point that you made. Our folks aren't getting infected with patient contact; they're getting infected with social and personal contact, and that includes. I just urge everyone to be vigilant in the station, group meals, masks in the station, because it's really been those sort of interactions, home, personal interactions with your spouse, with your family, that have been where we've had our infections.
So we're talking about, like, whenever you get the vaccine, you're gonna have some type of immune response whenever you get it, right? You're gonna have a fever, you're gonna have some aches. Should people take off work when they get it? The first round or the second round?
Right, great question. I mean, we're recommending, and Chief can chime in on our policy, we're recommending that people get it at the end of their tour, so they have a couple of days off. The median time that people have these very common side effects, pain at the injection sites we went over earlier, they may have chills and body aches, joint aches, bad headaches. They should not have severe shortness of breath or respiratory symptoms. That really is kind of more of an indicator of an active infection rather than the virus. So like Dr. Antebi tweeted about that the other day. I thought that was a pretty good point to make, that the vaccine side effects are all kind of constitutional. So chills and fever and body aches, but it will not make you short of breath. It will not give you cough and other respiratory symptoms. That's kind of where you need to, one of the other questions will go, well, if I have these, what symptoms should prompt me to get a test, rather than to just say, oh, it's the vaccine. It's, a day or two after the vaccine. And the median time those are going to last is about 24 to 48 hours. So we're kind of recommending that here, depending on what schedule you're on, that we build in some leeway there to let our employees have some downtime after they get this thing.
I work in multiple hospital systems, and all of them are basically using the same party line, and that is, for emergency physicians, when you get vaccinated, try not to plan on vaccination with a shift in the next 24 hours, so that if you need to, pop some Tylenol, drink some Gatorade, rest on the couch, that you can do that to anticipate some of those constitutional symptoms. I think an important point to remember about, can you contract COVID around the exact time you plan for vaccination? And as we start approaching these hundreds, thousands, 10,000s of people vaccinated, there are going to be people in that group that got COVID exposure 4 or 5 days before their vaccination, get vaccinated, and then start coughing. Start having vomiting and diarrhea. Start having those non-constitutional specific respiratory symptoms. And that's the group that it would be definitely a case-by-case basis, but we probably need to test in those situations. If you've got a little aches, a little pains, I think we would say, let's watch that. You start saying, I can't breathe, coughing, my chest hurts, might be headed towards a swab.
And when you're planning your vaccines, you got to look the 21 days out. You almost got to work backwards. That 21st day, you don't want to be on shift. The 21st day, you want to make sure you plan backwards.
And there is some leeway, plus or minus 2 to 4 days on each side. So that 21 days or 28 to 30 days with Moderna, those are not carved in stone.
Yeah, do you want to go over at least the CDC? I think they did publish it out now. It was on the listserv the other day.
I've seen plus or minus 2. I've also seen plus or minus 4.
I saw plus or minus 4.
Right, so I think that's probably, folks are still sorting that out, but I don't think getting caught up in 2 and 4 is really, I don't think we have to do that, but I think the idea is that if you get vaccinated on the 10th and you're going to take the Moderna vaccine, so you've got to go from December 10th to January 10th and look at probably the 14th to the 6th, right? You've got that time period in there where you can say, all right, does any of these fit? Do I have a 4-day off period, from the 9th to the 13th? Well, I probably want to get vaccinated on the 8th and the 9th, right? So that I've got 4 days, I can get through the constitutional stuff and go back to work. That way it's not confusing and you're not on shift with a little chills thinking, oh my God, am I giving COVID to my entire station?
Sean, any other questions that you guys can think of that we hear commonly from our crews or you've heard just throughout your interactions with EMS professionals?
I think you've hit a lot of them, Doc. And there's a lot of concern. There's a lot of just general questions out there. I think we're just looking for the right way.
Yeah, and I think that Sean says it best a lot of times. Our goal here is not to convince you one way or another. It's to provide you unbiased information, the best that we can do, the best information, the science that we all know, and from our experience of the patients and employees we've looked after here. And ultimately, that decision lies in what's best for you and your family. So if you do have additional questions, I know they come up, you may want to talk one-on-one, our doors are always open. You can always, if you're not employed here, you can send us an email at the podcast email, podcast@mchd-tx.org. So
just add on a couple things that we've not said. Number one, I've been asked, why so many vaccines? Why do we have 4? There are multiple shingles vaccines. We've got all these vaccines. We've got to vaccinate the entire world's population. So that's a good thing, not a bad thing. I would also say that, not taking the vaccine, so you come down, you listen to all this, you decide I'm not going to take it. That's not a risk-free decision. risk in that decision is you've got a greater risk of COVID-19 and COVID complications. So don't think there's a no risk decision in this whole mess. Unfortunately, SARS-CoV-2 is real, it's here. So if you decide not to take it, you're taking on that risk. And like Dr. Dickson said, I'm not going to tell you what to do, but I can tell you my own personal decision was to get vaccinated as soon as possible. So I would urge you to take that with a couple pennies, and there's my 2 cents worth.
Yeah, very good point. Point well taken. And we hope to have vaccine available for all of our employees that would like to get the vaccine as soon as we are working on it every minute of every day, trying to get it to you as quickly as we possibly get it to you.
Yeah, the key right now is it seems like it's hospital partners for the immediate future, working in the next couple of weeks, next month or so, and then we're looking at Montgomery County Public Health. To our relationship with them is so strong, we can work in, and hopefully by then we're branching out between phase 1, phase 2, and moving on to general public. But the key right now is just working with our partnerships.
And like everything else COVID-19 related, from the very first COVID podcast back in January of 2020, we withhold the right to step back and make a turn when data comes out, when information comes out that makes this obsolete, which I'm sure we will get more vaccine data. We'll get the Johnson & Johnson vaccine. We'll get AstraZeneca vaccine.
AstraZeneca will come out. We'll try to update you guys or put it on a podcast, get back this group from leadership together again so we can have another one of these QA sessions.
Just for dating sake, it's December the 21st on a Monday. We'll see how long this stays up to date.
All right. Well, thanks everybody for your time this
Yeah, thank
afternoon.
you.
Chief,
Very
Sean,
informative.
Dr.
Thank
Patrick. Thanks everybody for watching. Again, if you have questions or comments, please send them to the podcast at mchd-tx.org.